الرحيم. السلام عليكم ورحمة الله وبركاته. وأولا أحب أشكر الزملاء المنظمين وعلى رأسهم الدكتور نزار على دعوتي للمشاركة في هذه الندوة ممتازة جدا الحقيقة، لو أني فاتني أول يوم وبعض أمس، فأشكرهم جزيل الشكر. My talk today is nothing fancy, but it's common problems which we face in the clinic. So it's not going to be an exotic cases like the previous case or something which is very difficult, but it's a day-to-day practice which most of us see in the clinic, but sometimes it causes for us a dilemma what to do with the patient, and probably some of us will have a different approach to these cases. So I'd like to have first of all to expose the non-specialists, our residents and general doctors to these cases and to give them an idea about it, and to have the opinion from my colleagues, the infectious disease consultants, what they recommend and what they do for such cases. We start Bismillah ar-Rahman ar-Rahim with the first case. It's very common, almost in my clinic every week, a new case, and I follow probably at least two or three follow-ups in the clinic. 30 years old Saudi gentleman referred from the PCC. Sometimes we get these cases referred from the surgical clinic or from the ENT clinic with cervical lymphadenopathy. This is a very common. I don't know why they choose infectious disease clinic to refer such cases. Why they don't go to surgery and surgeons refer them to us. Nobody wants to take decision about such patients who come complaining of cervical lymphadenopathy. He noted the swelling in the right side of his neck during shower about 3 months ago. It is painless and has not changed in size since he noticed it. No fever, night sweating, or decrease in weight. He is a smoker for the past 12 years. He is single with history of sexual contacts abroad. His physical examination showed multiple small, sorry about the mistake, small cervical lymph nodes. The largest is about 2 by 2 centimeters. No other lymph nodes were palpable, and no splenomegaly. His initial investigations, which were done in the PCC, CBC, UND, and chest X-ray, were all within normal limits. His HIV, which I requested, was negative. The patient is worried about his condition because one doctor told him it might be cancer or TB. So what do you do usually in this case? You just, this is the 4 questions, and just I want to see who will go with the first one. Reassure him that this is not significant lymphadenopathy and no further action need to be taken. Who will go with this opinion? No one. Huh? Nothing. That's basically small lymph nodes. Okay, maybe you have a 4th one or a 5th one, we'll come to it. So nobody will go with the first one, reassurance? No? Okay. Who will recommend FNA from the largest lymph node, which is apparently about 2 by 2, for cytology and Nielsen stain and TB culture? Okay. Nizar, anybody else? Dora? Okay. Who will do tuberculosis skin test, and if strongly positive, and I put this quote unquote because what is strongly positive? Is it above 15, above 20, or 25? It depends what you understand from strongly positive, and treat for TB. Without biopsy, without FNA. No one, which is good. Recommend excisional biopsy right away for definite diagnosis. Everybody. The majority will come. Anybody has a 5th one, which isn't, I did not include? ESR normal, LDH normal. Yes. Huh? Okay, I will not give the answer because there is no right answer. Okay, let us just discuss the lymph nodes. When to consider a lymphadenopathy a serious disease, and you have to really go aggressive in further investigation. this is just to give you an idea about the sensitivity and specificity of the physical signs related to lymphadenopathy. This is from a very nice textbook about the evidence-based physical diagnosis. I recommend every resident to have a copy or to buy it because it's a very nice textbook. Basically, how I got, okay. So these are the positive predictive signs, and this is the negative predictive signs. So we'll come to the score, the lymph node score. If it is above 7 or more, it is highly positive predictive. There's the chance that this is a serious disease like lymphoma or metastatic disease or tuberculosis is more than 50%. If there is a fixed lymph nodes, which is not in this case, again, the predictive value is relatively high, about 45%, the positive predictive value. If the lymph node size, which is, you multiply, for example, in this one, 2 by 2, it is 4. So if the lymph node size is more than 9 centimeters, if the lymph node score is 5 or 6, then the predictive value will decrease slightly. If you have a supraclavicular or hard nodes, also it's predictive. Look at the negative predictive values, which will indicate that this is not a serious disease and it's not significant lymphadenopathy. So if the score is minus, or if the lymph node less than, than the age of the patient is 2. The score of the lymph node score is this. The age of 40, above 40 is given plus 5. If the lymph node tenderness is given minus 5. So if the lymph node is tender, then it is less likely to be a serious disease. The lymph node size, of course, depending on how big is the lymph node. So the bigger the lymph node, the more points you give. And the generalized pruritus, which may support malignancy like Hodgkin's lymphoma, supraclavicular is significant, and if the lymph node is hard, then you subtract as a corrective factor is 6. So if we calculated for our patient, his lymph node size is only 4, he's below 40, and he has no other symptoms. So his lymph nodes will be, lymph node size will be somewhere here, 3.99, so it will be plus 8. And if we've subtracted 6, so it will be plus 2. So if we go back to the previous slide, so he'll be somewhere here. His lymph node size will be really, score is, it's not in the minus, but it's about 2. So it is relatively low predictive value. Okay, this is in a clinical. Of course, if you have such a case, which is not the patient, of course, then the case is very obvious. This is a big lymph node. This is with erythema and about to have a sinus. And this is the typical of cold abscess from tuberculous lymphadenitis. And this is easy to diagnose clinically, and you want to confirm it with TB cultures. For a long time, the diagnosis of or the tuberculous lymphadenitis have been classified according to the size of the lymph nodes and the other signs from stage 1 to stage 5. Of course, stage 4 and 5 are very easy to diagnose, but the other stages are really not easy. You need really to diagnose using from stage 3 to 5 are easy to diagnose. But the first ones are not easy. You need to biopsy them and confirm the diagnosis. Most of the people recommend to start usually with FNA as a diagnosis. And the sensitivity and specificity of FNA depends on the clinical stage of the disease, of course. If you have very advanced stage, the sensitivity and specificity will be higher because you'll get more tissue, you'll get necrotic tissue, you'll get, if there is cold abscess, you'll get even fluid, which will be, the yield will be much higher from cytology as well as from culture and PCR. And usually you need to combine these. So you get FNA and you do Z-Nielsen stain, you send for culture and do PCR. Of course, the culture will take a long time. The yield from Z-Nielsen stain is usually very low. So you are left with the PCR. If it is positive, it is good. If it's negative, it doesn't rule it out. So the That's excisional biopsy is, of course, the gold standard, and it's the final thing you do. And most of us will go eventually to excisional biopsy because you don't get a solid answer from the FNA. But if you get a positive answer from the FNA, there is no urgency to go excisional biopsy right away. Most of the time, you can do FNA. You can see the patient in 2-3 months waiting for the TB culture. And then if it's not, or our pathologists, some of them are really confident and they can give you a clear description of granulomatous lymphadenitis with caseation. And then you can be confident. Some of them even write for you most probably tuberculosis. So you feel comforted to treat based on the FNA. But sometimes some of them, they don't really give you a definite description that you base your diagnosis on. Of course, if you have positive PCR or stain, then you are lucky to go for this. The question, do you have to rush for the biopsy or you can wait? That's what, so that's my, but that's what I'll do. I will reassure him that this is not significant at this stage and no further action need to be taken. Probably I will continue following him in the clinic every 3 months just to make sure that these lymph nodes are not increasing or in size or there is no new symptoms. If he's worried, then I will go for the FNA. Most of them really, I follow them for 2 years and nothing happens. They continue. I myself, usually, I take myself as an example. I have few lymph nodes, one of them at least 2 by 2. Since I was a medical student, I feel it. It is the same. It has not changed. And it is common in young men because when they shave, they get some lymph nodes and some papules. So don't worry if there is really small lymph nodes and no other signs and symptoms. You can wait. If it's lymphoma, it will show itself. Okay, I'll go to the second case. It's a little bit of problematic, although less common than the first one, but we see it maybe once a month or once every 2 months. 35 years old Saudi lady pregnant who's referred to you from the OP clinic. She's gravida 3 para 2 plus 0. Currently, she's about 20 weeks pregnant and found to have positive serology for toxoplasmosis. Both IgG and IgM were positive. She does not recall any febrile illness during the pregnancy and does not have cat at home. Her previous pregnancies were normal. She was followed in other hospitals, so we don't have any previous serology on hand. And she does not know about the toxo screening result in the previous pregnancies. Her youngest child is about 3 years old. Both she and her doctor were worried. What is the risk that her baby might be infected with toxoplasma, and what is your advice? Okay, any few options, but خلينا نشوف. So any comment? Huh? First time for you, yes. You don't know about her previous history, but she has previous deliveries which are normal. Sorry? We don't know. Maybe she had tests, but it's not available. If it was available, then it will be good. This is the challenge. The IgM usually reported not only positive or negative. Usually you are given figure, and it's variable from one lab to the other. Let us assume it is high. The IgM level is high.
IgG ability test, you do that, the ability test, to tell you it's an acute or a chronic illness.
Sorry?
Ability test, the IgG ability test.
ما فهمت.
Avidity, from avid.
Avidity, okay. Okay.
And it's not really normal because you care about it's acute, it's pregnancy.
So is this serology enough to tell you this is an acute? This is the question. So can you from this test, which is the only available, I'm not aware that we have any really advanced test in our labs. It is ELISA test available in every lab, government and private. It is ELISA test, and they will tell you IgG and IgM. Yeah. So IgM we can't take. So we don't. So the message really that this information doesn't tell you much. Let me see the options. You'll tell her that the risk is very low and reassure her and her doctor no further action, and again, sorry about the spelling, need to be taken apart from routine antenatal care. Who will take this approach? No one. So you are worried? Okay. The risk is very high. The opposite. Recommend ultrasound amniocentesis to rule out congenital toxin. So no one, these are two extremes. So you just ignore it, or you go aggressive on ruling out toxin. So which one you will go? Neither? Okay. The current tests are sensitive and specific enough to make any, are not, supposed to be are not, معلش. شكلي وأنا مسوي السلايدز عن نعسان. The current tests are not sensitive and specific enough to make a decision, and further tests are required. Okay. So the avidity tests are not enough, and you need to do more tests. Dr. Samar, anybody will agree with Dr. Samar? So most of you. What other tests you will request? And is it available for us in the kingdom? Dr. Muhammad Qutb, is it, where is there any lab consultant? What other tests are available for us for toxo? Huh? PCR. Is it available? Any lab in the kingdom can do PCR for us?
It's advanced testing. Fluid PCR is something to consider if you really want to nail this issue.
But it's not available. طيب, the easiest option, okay, say, I don't need to bother about tests, let me give her treatment. So start treatment with pyrimethamine sulfa since she's above 20 weeks, with regular ultrasound examination during pregnancy until delivery. Who will treat based on this serology?
But if anybody wants to treat and choose that because she's pregnant, actually pregnancy with rhabdomyosin, which is recommended.
That's in the first trimester. But above 18 weeks, it's recommended you can go with pyrimethamine sulfa. Of course, until the probably last 2 weeks of the pregnancy. Do nothing at this stage of pregnancy because you don't have specific tests. You don't want to go aggressive. So do nothing at this stage of pregnancy. Careful examination and investigation of the baby upon delivery to rule out infection. Who will go with this option? Nizar? That's true, but you may have I mean, major defects which will be apparent even antenatally by ultrasound or by. Okay. There are two other questions which I did not put here. What other options available for us? She's 20 weeks pregnant. Suppose you diagnose the fetus to have congenital toxo. Is abortion an option for us here in the kingdom? It is not. Nobody will agree to do abortion or terminate pregnancy because الفتوى تقول لك لا. ما دام ما في ضرر على الأم الطفل حتى لو كان واضح إنه يعني has some congenital defects, unless he's dead, then you should not do abortion. So the option for abortion is not there. What about the efficacy of a treatment in reducing congenital toxin? عفوا هنا. معلش السماعات في اتجاهكم فاحنا ما نسمع بشكل وضوح، نسمع الصوت بس.
What the status, I mean, whether she's having acute toxo or toxo reactivation during her pregnancy, you might consider cautiously empirical treatment for her. However, she's in the second trimester. I think further tests are needed and further evaluation cautiously. You might re-examine her and screen her for dermatopathy, ask to repeat the test, don't go by a single reading. You might do that in 2 weeks interval, 2 to 4 weeks evaluate.
Sure. Yeah. Repeating the test is an option, yeah, of course. The efficacy of a treatment, I will not discuss this the treatment issue in this presentation, but the efficacy, the effect of a treatment in reducing the chance of congenital toxo is questionable, really. No evidence that it really helps much. Okay, now we go to the risk of toxo after acute, or if there is an acute infection during pregnancy, is relatively high. And increases with gestational age. So if the patient got the infection after the first trimester, the chance of having congenital toxo in the baby is high. And so it increases by gestational age. And the chance that the baby will have more signs and symptoms at delivery will be high in the first and second trimester. As one would expect, if the infection happened in the first trimester, then the fetus still in the development stage, so the birth defects will be much more compared to the third trimester. But the chance of infection is higher in the third trimester. So there is a risk if she got. The question is how sensitive, how good is these tests which are used routinely for testing. Unfortunately, as Dr. Ghassan mentioned, the IgM takes long time to decrease, and it's not enough to confirm an acute infection. So of course, if both are negative, then your patient doesn't have toxo and she never had been exposed, but she remained at risk, and therefore she should be advised about careful not to acquire toxo. If the IgG is positive and the IgM is negative, this is again, it can tell you that this is either an old infection, very old infection that the IgM has decreased, or it is relatively recent, but it's not. So it's helpful if it's in the first and second trimester, but in the third trimester, it could indicate that the patient may have an infection in the first trimester and the IgM has declined to become negative. If in the second and third and fourth combination, which is negative and positive here and positive both, then the infection could be recent, but how recent, you cannot tell. Was it during this pregnancy or a few months before? You cannot tell. So really, it's not enough to make a conclusion about management in this case. So it says here, the IgM antibodies are detected early in the acute infection because they may persist. Prolonged period IgM antibodies may be detected in pregnant women who were infected in the distant past and before gestation. Therefore, positive or equivocal results should be followed by confirmatory testing. And the question is, do we have confirmatory testing in our labs? I don't have in my labs. I don't know if anybody has. This was again to tell you what other tests they do. They do more specific tests for IgM and IgM and IgA and IgE, and they do it in different methods rather than the ELISA to try to find out. So if you have a positive IgM, IgA, and IgE, using this is of course in Paltal Foundation. This is the reference lab in the United States, which is, they recommend in the US to send all the specimens to this lab, which is very difficult for us. And probably the lady will deliver before we get results. The recommendation in the US, I don't know if it is applicable to us or not, is that that's what you're supposed to do. When you get a positive IgG, IgM, you send it to the reference lab to see if it is positive or not, and then you proceed accordingly. If it is consistent with an acute infection, then the risk is high and you can start treatment, and if there is birth defects, you can even proceed to abortion. My questions to my colleague, what options we have here? We don't have except IgG and IgM. Really, we got challenges when you get this patient from the OB/GYN. If you are lucky to have to go back and see her previous pregnancy and what was the serology, then that's good. You get a reference. So if it was both positive, then that's it. It reassures you that she has. But if she was negative and then converted to positive, then again this will tell you that she had a recent, and you may initiate therapy. But if you don't have, which is most of the cases, what to do? Any?
I think I get a concern. Somebody asked about the ability test. Ability test.
Sorry. Yes.
Ability test is used to differentiate between primary infection and past infection, and this is by treating the sample with some detergent to get rid of most of the IgG. And most of it used for rubella that when we started, and for toxo, and for herpes simplex. That the three tests so far available, and it's FDA approved or CE approved, okay? This is to differentiate between primary from past infection by using certain detergent. Yeah, we do that in person, yes.
But you can tell it's relational.
Yes, available.
So we have it or we don't have?
Or if you have a high ability, it means it's more of a chronic serology rather than acute. So it's not an hospital. The interpretation of it.
It's ability, A-V-I-D-I-T-Y, ability from أبد يعني جائع. Right? This is the way they update the antibodies.
So it's available in King Faisal Hospital. It's okay. So maybe we refer to you our samples. Okay. Huh? Okay. Thanks.
I do remember a case, exactly like this case. She was pregnant and asking for a second test with a 1-week interval showed changes in the title. It was trending for treatment. And fully evaluated the patient, asking her again in a second visit, what does she think about the disease? She was an educated lady, and she told me, I think I have toxin. And I believed her. I followed that test with 2 weeks interval test. There was an increase in both IgG and IgM. I cannot explain that scientifically, really. That was happening in our lab. We started a clinical treatment. That was a case with my fellowship. We can't be done by the substance as in lab. They started a clinical treatment. We treated her, and then she delivered with bone follow-up. The titles started to go down. Eventually, we decided to treat most of the cases according to similar scenarios in our practice. And this is what I do until now. And I think we have few common cases during pregnancy presenting with acute toxin. And even if you cannot decide based on the referred test if it's acute or not, based on experience and our knowledge, it's common in our society and our parents and kids are unvaccinated. I think we need to start critical treatment if we have a doubt about it.
طبعا empirical treatment, the problem is again, the treatment is toxic, and if you don't have really definite acute toxo, you will be reluctant really to treat.
I come from Lebanon, which means we eat lahmi كتير. We have toxo all the time, so it's part of. And I used to see lots of cases. And basically, we didn't have the ability less or others. I would treat.
So you treat.
I don't take chances. And we used to give rapamycin for 2 months recommendations that were very safe for pregnancy. Not only data that analyze my patient, but I can't remember that I ended up congenital toxo. So even when we're not sure,
I cannot. I cannot disagree with you, definitely, but I'm telling you what is recommended. This is what I will do. Probably I will. I would probably see her again and repeat the test after 2-3 weeks, and to see if there is rising titers. Definitely, I will treat. If the titers are decreasing or the same, probably I'll just wait and see, and hope for the best. Do you agree with this? Okay, let us go to the third case for the sake of time. This is not as difficult, but we start seeing it more and more nowadays. Again, in every clinic we see 1 or 2 cases, or sometimes verbal consultation from our colleagues. A 40-year-old Saudi lady, known case of rheumatoid arthritis, not well controlled on conventional therapy, include disease-modifying agents like methotrexate and others. Her rheumatologist will start her on infliximab, or let us assume any other TNF inhibitors. Her TST, which was done by them, was before she came to you in the clinic, was reported to be positive. We didn't know, but somebody wrote in the referral form it is 10 millimeters. Her chest X-ray is normal, and she had no previous history of TB or known exposure to a patient with tuberculosis. She's a school teacher with good living conditions. She was referred to you for possible chemoprophylaxis. So what is your decision in such patient? I'm sure you see these consultations on a regular basis nowadays. And TNF inhibitors nowadays are used in many conditions by dermatologists for psoriasis and for even hidradenitis suppurata, and by rheumatologists. So we start seeing it more and more. So these are the questions. Repeat tuberculous skin test because you're not sure about the previous one. And if it is positive, again, more than 10 millimeter, you will start chemoprophylaxis. Who will go with this? Doctor, okay. No hands? Okay. Do IGRA if it is available in your hospital, and if positive, start chemoprophylaxis. Okay, a few here, and I will not add much, Dr. Summer. Okay, more in the male side, saying that they will do IGRA. Who have IGRA available routinely in their hospital? Inshallah. لا تصيرون من نفس المستشفى بس. It's not readily available, of course, in every hospital. We have it for research purposes, but we don't have it in routine. Huh? Okay, how would it add? The third option, no need for prophylaxis since the TST was borderline positive and the risk of TB is low. Do you agree? So if it is true, even if it is borderline positive in the standard basis for immunocompromised patient, it is positive. So actually the recommended for such patients is more than 5. It's like HIV, you have to consider them. So therefore, 10 millimeter is actually a good positive, but most of the time we get these patients and we have not seen the test ourselves, and we don't know who did it and how it is done. So you're not sure really was it done properly or not. Start prophylaxis anyway, since the risk of reactivation is very high, regardless of the TST or Nizar or Ali al-Barrak. Regardless of the TST done, يعني, if you are sure about it or not sure. Let us just review this subject a little bit. 5 minutes. لا لسه باقي لي انتم. إلى 25. إلى 25. طيب يلا almost finishing. طيب طبعا the risk of reactivation of tuberculosis with anti-TNF is really significant. It is